today.
Oh, happy birthday. What a better way to spend it. What a better place to spend it than Senate estimates. Okay, welcome back everyone. And I now welcome officers of CASA, and we won't be asking for opening statements. If you've got one, you can table it. Senator Fawcett.
You won't be asking for your age either, Ms Spence. You'll be glad to hear. Thank you. Well, in fact, this does actually take me back a little bit. I'm assuming in your preparation for your role you read through Hansard transcripts for many years, and you'd be aware that between 2014 and 2017, I and your predecessors had many discussions about colour vision deficient pilots. And eventually, as you would be aware, your predecessor, Mr Carmody, in February of 2020 announced to the world, and I'll read here from a statement he sent out, that research, so evidence, in recent years has shown that relying on diagnostic tests alone may be unnecessarily limiting when considering the impact of colour vision deficiency on aviation safety. Advances in technology, operating techniques and human factors training can now mitigate many of the safety risks of colour vision deficiency. The technology to assist pilots has developed significantly, and the impact of colour vision deficiency on aviation safety should take these changes into account. And at the end of his statement he says, CASA has carefully examined all relevant safety issues and believes this new approach, which is the same as New Zealand and the FAA, offers a practical alternative assessment for colour vision deficient pilots. We've listened to the views of pilots and made judgments based on research and evidence, which is a fantastic outcome. They changed the lot of pilots, which had been thrown into confusion by a new senior medical officer within CASA who didn't like Australia's position, which was to allow pilots to do an operational test, and despite losing AAT cases, etc., and reviews of evidence that finally proved we should do this operational test like the New Zealanders and the FAA, it's all happening again. Could you explain why CASA is spending $500,000 on a review, and what is the evidence base to justify this change of position? What incidents have occurred? What evidence has led to the decision to spend $500,000 of taxpayers' money and overturn what has been in the CASAs for some years now to the detriment of a group of individuals in our aviation community?
Well, thanks, Senator. Pip Spence, Director of Aviation Safety at the Civil Aviation Safety Authority. I wouldn't describe it in the same way that you have in terms of, someone coming in and not supporting the previous position. I will ask our Principal Medical Officer if she wouldn't mind joining us at the table. But I think the first thing is really it's a question about what's consistent with the standards versus what's okay from an operational perspective. And I don't think we've changed our position about that there aren't ways of overcoming the issue of colour blindness from an operational perspective. I think there is a different question about whether that is consistent with the standards, and that's a harder question to answer. So I might pass to Dr Manderson to provide a bit more detail, Senator.
Dr Manderson, welcome.
Thank you very much. So regarding the colour vision assessment, what we found a couple of years ago and going back a bit before that was that there was a lot of difficulty and confusion in how that colour vision was being applied by the flight instructors that were assessing the pilots with colour vision deficiency and the pilots themselves in what they would be expecting to be demonstrating in their flights. So we had some difficulties where the forms and the flights were not being conducted consistently to a consistent standard across the board, where someone might have one kind of flight or assessment with one assessor and a completely different one with somebody else, with someone else. So with that degree of confusion and lack of clarity, we realised that having established that an operational flight-based assessment was really important, absolutely, how we did that was where there was a big gap in what we were doing and why we were doing it that led to all of that confusion and some difficulties in what standard was being met by whom and when. So that's why we saw that gap in the how that hadn't been filled by any of those other organisations or jurisdictions. So we've consulted really quite extensively. Even last Friday we had an international meeting here in Canberra with our colleagues from FAA, New Zealand, ICAO, the United States military have come across as well to share their experiences with us and how we do that now. And there really is a global consensus that the approach that we've taken is world leading and will make a big difference to the consistent application of a good standard that our instructors and our pilots can rely on to make a safe decision.
Sure. So I don't have a problem with standardisation. I think that's excellent. I do note my understanding is that New Zealand did have a course to standardise their examiners, which we didn't adopt, even though we adopted their operational test. Am I correct in my understanding of that?
I'm not familiar with the detail of the way the New Zealand team initially applied theirs, but they're certainly very excited about looking at what we're doing and learning from what we're doing, because we've gone to sort of next level, so much more depth, much more comprehensive. And the CAA New Zealand Chief Medical Officer is very interested in learning from what we've done.
Sure. So my understanding is because we didn't have any standardisation initially, the initial batch of flight examiners actually went to New Zealand to get their training there, and in fact we encouraged or enabled, if pilots wished to bear the cost to go to New Zealand to be tested by the New Zealanders, that we would accept that as a valid medical, so from a system that did have standardisation and did the test. So I don't have a problem with standardisation. What I have a problem is, when I look at your website, we have gone back to the days of saying if you pass the operational test, we are still going to limit you in terms of what you can do as a pilot. For example, fly as or with a co-pilot. On what basis, what evidence has been put forward, given everything Mr Carmody said, given everything the AAT found, and cases back in ancient history, 30 years ago now, when Australia became a world leader, what evidence justifies that imposition of a restriction on someone who passes the operational test?
So the evidence is based around the demonstration of being able to do the elements of the flying task that have been assessed by this international group of expert pilots and flying instructors as to what are the time-critical, safety-critical, colour vision-dependent tasks of the flying task. And that was a gap that wasn't there in the work that was done leading up to the New Zealand assessment that we've now been able to produce. So the evidence is around, it's not about the medical diagnosis, it is what it is with the diagnosis of colour vision deficiency, but the evidence is now about being able to know exactly how that medical status affects this person's fitness to fly and fly safely. And that's exactly the same as we do with people with kidney disease or hearing deficiency or heart disease. They don't meet the standard, but now we can in very great detail and very safely, effectively and consistently assess whether or not the way they meet the standard presents a hazard to safe air navigation. And that's the way we do all of our medical assessments.
Sure. So, in theory that is fine, but what you're describing is that your test is now focusing on some discrete task elements that you believe are important. But what your website says is that even if someone passes that test, so it has now jumped through these additional hoops of specific tasks, you're still going to put limitations on what they can exercise as captain in command of an aircraft. What is the evidence to justify those limitations? That is my question.
So, Senator, if I can jump in. Andreas Macheza, I'm the Executive Manager for the Stakeholder and Engagement Division, and the website and some of that information sits in my area. I think what you're describing, if that is correct, is not our policy. So our policy is that there are various conditions that we can put on medical certificates depending on how you go in the test. But if you pass the test and demonstrate that you're operationally safe, there is no condition of a co-pilot. What Dr Manderson is saying, though, is that because you don't meet a medical standard, so you have not met a medical standard that's internationally accepted, but you have proven you are safe, we will grant you a medical certificate. So we can't say that you've met a standard, but we can say you're safe to fly, and those conditions will be applied depending on the way you've gone. So I think if that's on our website, I'll take that up because that's not the policy.
Sure. So 2 points. One, I think it was amply proven almost a decade ago and 2 decades before that that as we dug into the history, those standards emerged from maritime standards that were applied in the United Kingdom in the days of Sopwith camels and things into World War I. And the reason we no longer require them is that we have secondary means of communication. We've demonstrated through a whole range of flight profiles and cockpit modifications, particularly with the advent of EFIS screens, etc., that many of the old colour hierarchies around warnings, etc., are no longer relevant. They're not required to do the task. Even the red and green lights are not required when pilots wear Bluetooth headsets. So I come back to the fact that your website, and at this stage this is what industry is seeing, okay, your website states that a pilot who passes the test will have these restrictions until they have, let's get the figures here, 100 hours of flight at night, so the ATPL standard, or 75 hours of instrument time. And as I've done just a very quick bit of research on the current costing of something like a Cessna 172RG, which is the kind of aircraft for night VFR or instrument flying, the costs between Moorabbin, Dubbo, Adelaide, Sunshine Coast vary from about $250 to $355, excluding GST. So we're putting a burden on pilots who want into the industry of $30,000 to $40,000, and I'm not aware of any evidence that would justify those restrictions if they have passed the operational test.
I think, Senator, what we're saying, we think our website's wrong. So we will go back to review it because that doesn't sound like our policy. While we've, as Dr. Manderson said, we're working internationally, looking at how we actually manage this issue. But the whole point was, if you pass the test in the simplest terms, then you've got a permission to fly, and those sorts of conditions you've just described should not be applying. So if you can bear with us, we'll review the website because it just doesn't sound right what you've just read out.
I'll have a look tomorrow afternoon. I'll be very pleased to see that gone. My last question then is, my understanding is that in accordance with the regulation, which I could look it up, I've got it written here somewhere, but I'm sure you know what it is. In accordance with the regulation, CASA was still advising pilots to do the operational test, which they did at some cost, and then AVMED were denying them an aircrew medical because CASA had changed its mind, even though the regulation still said it was possible, and even though pilots had been directed to that. And so some pilots now, in excess of 12 months, have forked out thousands of dollars to take a flight test and have had their application refused. What is the situation for people who have previously done it before this change in approach? What is the situation for those who did it in this intervening period where the regulation said they would be approved, they committed to a flight test on that basis, and have now been told they're not able to fly? What is CASA going to do to A, enable those people to move ahead with their life, and can you guarantee there's going to be no retrospective action against the many pilots who did the original 2020 announced operational flight test, have been flying single pilot in RFDS type operations, multi-pilot in RPT operations, both domestically and overseas, without incident since they got their medicals? Can you guarantee that they will be able to continue to exercise the qualifications that they have earned in accordance with the regulation, or will there be any retrospective action that CASA is looking to impose upon them?
Can I just sort of jump in first? If you've got people who've come to you saying that they haven't been approved, then I would really encourage you to refer them either to myself, to Mr Marcellia or Dr Manderson, because that doesn't sound like that's consistent with our policy. I would have thought with medicals, there are things that come up every 2 years or whatever, depending on where you are, and so there would be no retrospective requirements. But if matters change over time, then to get your medical renewed. But there's certainly not an intention to have a retrospective element to all of this. But again, encourage anyone who's spoken to you who said that they've been refused on the grounds that you've described, please encourage them to talk to us, because that just doesn't sound right.
And my last question, Chair, before you wind me up, is that industry had been told that the new test and all of its conditions would be released in September this year. We're now approaching the end of October. So where are we at, and when will these people have some certainty about their future or current career?
Yeah, so, Senator, we have slowed that down just a little bit because we're working through some of those implementation issues that you just mentioned. So, like Ms Benz said, we don't expect people to automatically have to prove things themselves, but where we've discovered that a test maybe has some uncertainty around it, we might ask somebody to do that test again, and in that circumstance we would fund that. But these are the policies that we haven't yet settled, which is why you haven't seen a policy come out. So they haven't been finalised, but they're very close. So, as Ms Benz said, we'd very happily follow up any individual case where someone's been disadvantaged, because our understanding was that the existing scheme was in place while we were settling the new one.
And no one had been, as far as my understanding is, no one's been refused.
There's been no refusals or cancellations for colour vision deficiency.
Okay, I will go back to the email trail that I have been given and see if I can see whether there's substance to what was reflected in that email, and if that's the case, to you, Ms Spence,
that'd
who's
be
the
great,
best
thanks,
person
Senator.
to...
Yeah.
Sure. Okay, thank you, Chair.
Thanks, Senator Fawcett. Senator Roberts.
Thank you, Chair. Thank you all for appearing tonight. Dr Manderson, the last 2 times I've requested your attendance at Senate estimates, you've been otherwise engaged. Does your role at CASA have your full attention?
Senator, can I just intervene briefly on that question? The first time I think that Dr Manderson was travelling overseas for CASA work, and the second time we only got notice, I think, 24 hours before the actual estimates hearing. So I think to suggest that Dr Manderson wasn't available and didn't have
That's true, so wipe that. But does your role at CASA have your full attention?
Yes, it does.
How many hours per week do you complete work specifically in relation to your role as Principal Medical Officer at CASA?
I don't keep a logbook. I would say it's in excess of 40 to 50 hours per week.
Are you full-time with CASA?
Yes.
What other roles and positions do you hold on boards or businesses?
Any roles that I have all been listed and notified to CASA on my required reporting. So.
Do you have any personal businesses, clinics?
Senator, we went through this a couple of hearings ago.
I want to hear from Dr Manderson.
But Senator, there's nothing further that we would add to what we told you previously. And from my perspective, Dr Manderson has done the same thing as all CASA staff do, which is she's provided advice on any potential conflicts of interest, mitigation arrangements have been agreed, and to my
Ms Spence, the senators asked questions. I have a question of Dr Manderson. I want her to answer.
Well, Senator, as I said, I'm happy to turn to Dr Manderson, but I do feel
Thank you.
that there has been advice provided to this committee previously.
Thank you. Dr Manderson?
Could you please repeat the question?
What other roles and positions do you hold on boards or businesses?
So I have declared on my declarations that I have a role on the Australasian Society of Aerospace Medicine Board. I have a role on the Australasian College of Aerospace Medicine Board. Both of those have been declared to CASA, and also, of course, my role at CASA is declared to those boards, and the potential for conflicts are managed appropriately there.
Do you have any clinics that you operate?
I have businesses that support doctors in their practices, but
Could you tell me more about them, please?
Sure. So the structure...
And are they declared?
Yes, they're declared. The structure of the way many general practice services work in Australia is that there is a company that's set up that employs the nurses and the receptionists and pays for the electricity and pays for the internet connections. And the doctors that work in those clinics see their patients in those clinics, and they're supported by the nurses and the receptionists and the internet and the computers and whatnot. So I have a service company that provides nurses and receptionists so that other doctors can look after their patients.
Do you work in those clinics?
No.
Have you ever received benefits or payments, directly or indirectly, for the administration of COVID-19 vaccines or injections?
I was operating a GP respiratory clinic under the Commonwealth GP Respiratory Clinic program. and those clinics were funded by the government to deliver COVID vaccinations and to do assessment and testing for people who may have COVID.
So that was while you were doing your job at CASA?
Partly.
Partly. Could you tell me more? What do you mean by partly?
So I established the clinic in Sanctuary Point, GP Respiratory Clinic, in early 2020, and I started with CASA in July 2021, and the respiratory clinic was closed in September 2022.
Thank you. What is the definition of subclinical?
Subclinical is a term that's usually used to describe the fact that someone has the presence of an illness or a symptom or a syndrome that is not overtly obvious to them or to other people. So an example might be subclinical hypothyroidism, where we do a blood test and we find that your thyroid level is low, and it might be causing some non-specific or vague symptoms, but it's not really obvious to everybody. That would be subclinical hypothyroidism.
Thank you. That was excellent. We had evidence at the last estimates that the buck stops with CASA in regards to determining whether a pilot is fit to fly, aviation safety and medical certification that would support aviation safety, and no other department has responsibility within that remit. Do you accept that, Dr. Manderson?
Only to suggest that the buck stops with the individual pilot to make their own self-assessment of their well-being each time they walk out to the aircraft, and we encourage them to do that every time.
So apart from that, you agree?
Yeah.
Can you confirm neither you or CASA have evaluated the aeromedical implications of the pilots taking the new mRNA technology injections at low atmospheric conditions?
No, we haven't.
Sorry?
No, we haven't.
Okay, thank you. Do you consider that you have any additional responsibility to evaluate in an aeromedical context, or at least surveil a new medical technology that only has provisional approval?
No, that's not the responsibility of the Safety Authority.
Okay. So you don't think you have any additional responsibility, yet you agree the buck stops with CASA for aeromedical safety?
If somebody is unwell enough that they can't fly and has a medication that means that they can't fly, then we would look at that. But we don't decide whether or not a medication is safe.
How does a drug make it to prohibited or restricted use for pilots?
Senator.
Dr. Manderson.
So we look at the work that is done by the authorities that are responsible for assessing medication safety and approvals in Australia, and we have a look at all the literature and the evidence that's available based on the assessments by those expert authorities to see whether or not there are any aeromedical implications for that. So, for example, a new antidepressant might change the way someone thinks or feels, or might be sedating, and so we would look at the degree of sedation that that antidepressant has been shown to have and decide whether or not a person ought to fly or not fly while taking that antidepressant.
Thank you. So who completed this evaluation for the COVID-19 products? Injections specifically. Dr. Manderson. AvMed looks at all medications that are available to pilots to see whether or not they're a concern, and so they were assessed by the aviation medicine section in the same way we assess any medication that's available to pilots and air traffic controllers. The answer we've been given before is that we relied on the experts who weren't named.
Senator, I think what Dr. Manderson is saying is that we don't do the actual assessment of the medication, but knowing what we know about the medication, we assess whether it will have a negative impact on a pilot. So we do not go into the detail.
Okay, let's continue then. Committee, I want to respect the committee's time. I've got a few questions to go through. In answer SQ 23-003972, CASA states it has no role in the Black Triangle medicine scheme. The TGA says the Black Triangle means that the medicine is new or being used in a new way. We encourage people to report any adverse events for these new medicines to help us build a medicine safety profile over time. So that's the end of the quote. So CASA does have a responsibility to report any adverse events if it comes across them.
The Black Triangle is designed for the people who prescribe, dispense, administer or take medications, and that's not part of the role of the aviation medicine section at CASA.
In a February 2022 Zoom meeting with Virgin pilots, Dr. Manderson, you stated that the provisionally approved mRNA vaccines or injections can cause myocarditis and pericarditis, but that you'd rather pilots got these conditions from the vaccine rather than COVID, which you claim to be higher risk. What evidence do you have to substantiate that claim that the risk of myocarditis is higher from COVID infection?
So there's extensive medical literature and evidence.
Could you give me the references, please? Titles, authors,
Not
publication?
immediately, but
We can take
No,
that
no,
on
on
notice, Senator.
Thank you.
Sorry, have you got any more? I'm not going to cut you off.
Just-
I might go around and come back if you've got more.
Just on this thread, I've just...
Okay, just on that
more,
thread,
yeah.
then I'll go across to Senator McDonald.
Can I point you to a study entitled, quote, COVID-19 Associated Cardiac Pathology at the Post-Mortem Evaluation, a Collaborative Systematic Review. That's the title. Published in the Clinical Microbiology and Infection Journal, 23rd of March 2022, which concludes that there was no increased myocarditis as a result of COVID infection. Can you please take on notice to provide what evidence or studies you have that refute a systematic review like that?
sure.
Thank you. In relation to question on notice SQ 23-003393, does CASA still not capture information in your medical record system in a way that allows conditions like myocarditis, Guillain-Barré syndrome and other COVID adverse events to be accurately reported?
So we do capture that information in our medical records system. So we ask every pilot and air traffic controller that's applying for a medical certificate to tell us if they have any symptoms or signs or diagnosis of any of those conditions, and they can write that in. We also ask their doctor, their medical examiner, to write in any details about any of the diseases or diagnoses or symptoms that pilot or air traffic controller may have.
So there are no incidents. Well, how exactly do you know that? If you can't give me a report of how many cases of myocarditis or any other recognised side effect you've recorded for each year, how can you say that there have been no pilots with adverse events?
Senator, the way we answered that question to you when you asked the question was we said
I'm
that...
after Dr. Anderson.
No, the medical record system is my responsibility, Senator. So
my question is still to Dr. Anderson. She's overseeing the whole of CASA.
Senator, my view would be that the most...
I didn't ask for your view, Ms. Spence. I asked for Dr. Manderson's view. I want to know...
But it's not Dr. Manderson's responsibility. It's Mr. Marcellia's responsibility, and he is trying to answer the question that you asked, Senator.
She's responsible for CASA's safety and aeromedical...
Mr. Marcellia is responsible...
I want to know her relationship with that. I'm asking her if she knows...
That's a different question, Senator.
That's correct.
Senator, Dr. Manderson sets our medical policy. The medical record system does not capture...
How exactly do you know that, Dr. Manderson?
Because it does not capture the information about whether there was an adverse event, whether it was simply a suspicion of an adverse event.
It doesn't capture that?
It captures comments that may have been entered into
So is it
clinical record.
Is it capturing it or not?
It is not capturing it in the way that you're asking it, and that was what we provided to you on notice.
How does it capture it?
Free text comments which might refer to symptoms, they might refer to diagnoses, they might refer to a comment that a patient made. So it does not capture the information in the way you've asked, and that was the response that we gave you to your question last time.
Final question on this thread, Chair. Does CASA, Dr. Manderson, does CASA still maintain that no pilot has been grounded or had a medical restriction placed on them because of a COVID-19 vaccination injury?
Yes.
Thank you, Chair.
Thank you. Senator McDonald.
Thank you very much, Chair. Dr. Manderson, I was in the Northern Territory the other day and met with a pilot who lives at Mataranka, 400 kilometres south of Darwin. He requires his medical every 2 years to maintain his licence. And until 2019, he was able to visit a designated aviation medical examiner in Katherine. Now, from the four, is it dames or damies? Damies registered in the Northern Territory on the CASA website. Only one conducts medicals just once a month at Alice Springs, which, as you know, is 1,100 kilometres from where this particular pilot lives. So we've got a damie shortage, I assume. Do you know what's the problem? Less GPs registering to carry out this work?
So I would suggest that it's not so much a damie shortage but a distribution issue, so which is a symptom of the health workforce issues in rural and regional Australia across the board. That's one of the reasons why we've looked at training more damies, particularly focusing on damies who live in rural and regional areas. And at our Brisbane Damie course earlier this year, we did have a doctor from Alice Springs, happily, who's now going to be a damie there.
Nobody north, nobody Katherine or Darwin?
Unfortunately, we can't compel GPs to choose to take up this particular role. We just invite them to and encourage and provide that training to them if they choose to.
So I appreciate you can't force them to, but this is problematic for it to be the closest one to be 1,100 kilometres away. Do you have a plan for what you might be proposing to do going forward?
So I would say that's part of the plan for looking at ways to get medical certification without needing to see a DAMI, and that's some of the new programs and systems that we're looking into. So a self-declared medical certificate where the pilot can assess themselves in collaboration with their treating doctors, and a GP-issued medical certificate in future as well, which means there's less need to see a DAMI for all those pilots. Hopefully that will make a difference.
That is very exciting. I can hear cheers all over the country.
Absolutely.
Watch this space, Senator.
Very exciting. That's terrific. Okay. I'd like to just ask you, Ms Spence, about staff employment. How many do you have in Cairns? Do you have employment numbers with you?
It's about 20, 21, 22. I think there's a lot of 20.
Okay. So there was 23 or 24 at the last estimates. Do you think, would you like to check that, or do you think we've lost some in Cairns?
I think we might have lost one or two, but I'll just, it's 20.
20, right. How many in Darwin? Yeah, that's true.
Hello, Senator. Philippa Crome, Executive Manager of Corporate Services. By head count in Darwin, we have 9.
Western Australia?
Perth, we have 45.
So I've covered off on Cairns and Darwin. Do you have any other staff employed in Northern Australia?
No, not in Brisbane, but not Northern Australia if it's defined as the standard definition. Yep.
So we've lost 2 staff from Darwin and 3 from Cairns. And what's happening? Do you intend to replace them? Are you advertising those roles?
Probably one thing to start with is we do operate with a national model, and so just because a staff member is not based in Cairns or Darwin does not mean they might not do activity in Darwin or Cairns. For example, we've recently we're in the process of doing a surveillance sweep across Northern Australia, and that's involving staff from some of our other offices travelling to Northern Australia and being involved in those kinds of activities. We do actually have recruitment activity underway, and one of our priority areas is getting technical staff in Queensland. Whether they'll be based in Cairns or Brisbane is a question, really. To be honest, we just want to get the technical staff who've got the skills and expertise into the organisation, because we've got the same issues as other organisations getting those people with the right qualifications. We can manage them operating in any of our offices, and we can just make sure that people can travel. Okay.
Do you have any offices on airfields anymore?
No, we don't, Senator. I don't think. Which one's
Darwin is.
Oh, Darwin. Darwin office is still at the airport.
I get a lot of feedback about not having staff.
Yeah.
Where you operate, where the aircraft operate. So at the May estimates, we discussed the airstrips in the Torres Strait and the Civil Aviation Authority applicable to the 3 strips there. And you know that tragically a life was lost only a couple of weeks after that estimates hearing because air services were not able to be provided. Has a solution been developed allowing services to be restored to these islands?
Yes, Senator.
To all 3?
Yes, to all 3, and we've also got 2 airlines that are operating there, both Hinterland and Skytrans.
So what was the solution that was provided in the end?
It was extensive testing of the operations that Skytrans have in place with the particular aircraft that they're using, but I might ask my colleague Mr Monahan to provide a bit more detail.
Sure. Evening, Senator. Chris Monahan, Executive Manager for National Operations and Standards. As Ms Spence pointed out, what it was a more robust safety case that aligned how they were going to actually operate, identified the controls that they suggested that we agreed to, that now make them safe, because one end of the runway on one of them was different, required a slight modification. Once we settled that, they were then able to operate into there.
So who paid for the modification of that end of the strip?
They didn't modify the end of the strip. They provided the way they fly the approach and the way they managed the arrivals was different and cognizant of what was different about that end of the runway versus the other one. So basically they did an individual assessment of each runway in the end and then found that what they had is suitable and that enabled us to reduce the factoring for them to allow them to get in there.
Yeah.
So you know my opinion on this. There were no incidents reported. There was no safety case raised. You implemented a system that meant that those islands didn't have a service. And then the final solution was that the pilots assessed how they landed there to land in a safe way.
Well,
No.
Sorry.
They do it different than they did before. They do it with additional controls in place that make them safe and appropriately safe for what the type of operation they
Did
want
they
to do.
introduce them to satisfy CASA or because they were safer?
Senator, it's definitely safer, and I think you would appreciate as much as anyone that regulations is always a balance between.
Okay, let's not talk about this anymore because I will get too distressed about what was the outcome and no interim. So you mentioned in the May estimates that there were other aerodromes that would have similar issues. And I believe you were referring to airstrips were built before, such sophisticated aircraft were using them. What other airstrips would these be?
I don't have a list of the airstrips. I think the only operator that we've currently got any issues that we're working through with is the RFDS services, the Queensland RFDS, and We've got arrangements in place that allow them to continue to operate to some of those smaller strips which don't meet the same arrangements, but because of the nature of those operations, they're not a commercial air transport service. That's allowed us to have a slightly different approach with the Queensland RFDS. I think that's the only ones. Yeah.
So are there any strips that you've prevented the RFDS from landing on?
There are some strips that we're monitoring closely, and we've given them approval to operate there while they work through what they might need to do to their aircraft to be able to operate to those strips in a way that meets our requirements around factoring that we've discussed in.
These in Queensland, Northern Territory, Western Australia?
These are in Queensland.
Is this because they're using twin-engine aircraft and not the Pilatus that they use in other states?
I'd have to.
It would depend on the type of aircraft and its performance capability, depending on what runway and combination.
Could you provide me on notice those list of airstrips and the reasons why there's some restrictions on them?
Absolutely, Senator. What I just wanted to say is that we're not impacting any operations at the moment, so we're working through that, but there's no one's operations being impacted to our knowledge in terms of restrictions. So we'll absolutely get you a list of where we're working through it, and we're also working with the department on whether we can identify any strips. So our intention is to try and get ahead of it so that we're not in a situation where someone's stopping.
I certainly hope not, because the problem with RFDS is they don't land at a lot of places. And so, I know people who have lain on in remote places because the RFDS can't land and pick them up because they can't land on roads and they can't land on other places that they were designed to be useful. But, Northern Australia, nobody gives a bugger, so let's not talk about it. Who's going to pay for the upgrades of these airfields?
Well, Senator, at this stage, we're working through with the operators to see if there are things that we can do that would, a bit like with the Torres Strait, how they can demonstrate that they can operate safely. It's more likely to be modifications to aircraft at this stage, but obviously that's still something that we're working through.
Okay, there was a suggestion that I think the other Assistant Minister suggested that the councils could apply for money from the remote airfields.
That's correct.
Have you put together any suggestions, assistance for those remote councils to assist them to apply for those monies?
We haven't identified any that would. We know the only solution is physical investment in the infrastructure. So we haven't as yet, but obviously we talk regularly with the department and understand what how their programs operate.
Okay. On notice, can you provide me the list of the 6 other airstrips for the Torres Strait, if I haven't asked you that already? Well, at the last estimates, you told me there were 6 other strips.
Okay. I don't remember the number, but we'll certainly provide the
Thank you.
strips.
You mentioned that you met with the council in Cairns a few weeks before the last May estimates.
Yeah.
I assume that this was the Torres Strait Council?
That's correct.
Did they travel 800 kilometres to Cairns to meet you, or did you travel to the Torres Strait to meet them?
We met in Cairns at their suggestion.
And my understanding, Senator, was they were in Cairns for their other business, so they didn't travel just to meet us.
Okay, terrific. And you identified, Ms Spence, at the last estimates that CASA regularly reports to the Minister, and you could include an update on these issues at these estimates. Could you provide that update to us, please?
I think I said, you asked if I was going to make sure that the Minister was aware of the issues, and advice was provided to the Minister as part of our normal quarterly reporting.
So the quarterly reporting, I think, is what I was referring to.
That's right. We provided an update in the quarterly report just to ensure that she had visibility of the issue and the actions that CASA was taking.
Is there any legal action proceeding from the incident in the Torres Strait?
No, Senator. Not that I'm aware of.
Coronial inquest?
Nothing that's been raised with us.
Okay, so at 2:15 today, the Senate Table Office included a link to the CASA annual report. The chair of the CASA board presented this to the Minister, Mr Betts, on the 20th of September. Is that correct?
That sounds
that
correct,
sounds
Senator,
right,
yeah.
Senator, yeah.
Assistant Minister, why has it taken so long for this report to be tabled? Is there a coincidence it's the middle of estimates week?
I don't have that information before me, but I can certainly give it to you.
That would be helpful, because I don't, it was tabled
100%.
with the Minister and the Department, Mr Betts, and yet it has taken a month.
Yeah. And I think, Senator, and again, probably better place to the Department, but there'll be a process that would have to be worked through from when we provide it, briefing will be provided to the Minister. There are a large number of portfolio agencies within the Minister's responsibility, so...
Ms Spence, you no longer have to provide cover for any Minister. Senator McDonald is absolutely correct. It is an obscene amount of time for an annual report to sit in a Minister's office and then to be... it's hard not to be cynical that it's dumped, it's tabled in the middle of estimates. So how are we supposed to ask questions about it? Supposed to be tabled in a timely manner so that people that are interested can ask.
As I said, I don't have that information before me, but the way you've characterised it doesn't mean it's correct.
It doesn't.
And I will get the information as soon as we can.
So one of the first parts of the annual report was that the CASA supported DAMI training in Fiji from April to May of 23 with funding support from DFAT to sponsor 6 doctors from PNG, 3 doctors from Fiji and 1 from Tonga to participate in the DAMI training. What was the cost of that training in the Pacific?
Senator, that's usually met by the Department of Foreign Affairs and Trade as part of the broader Pacific engagement, so I'd have to take that on notice, but it may actually be better directed towards the Department of Foreign Affairs and Trade.
So there was no cost for CASA staff for contracts to conduct the training?
No, Senator.
Okay, terrific. That is the end of my questions. Thank you.
Okay. Any further questions of CASA?
No. Oh, yes, there is one. No. Whatever one it was.
Right, okay. I'll try and do this quickly as I can. What regulations does CASA use to authorise the conduct of emergency service response aviation activities within Australia?
Can you provide a little bit more context to that question?
Well, in response to emergency services, or when you do need to respond, what activities do you provide, or what services do you provide in an emergency?
Well, when we've got massive planes dumping water or
If you're-
fire retardant.
The emergency for that kind of recovery you talk about would be Part 138.
Which is regulating aerial work.
Sorry, apologise.
Right. So, So does the regulation authorise the use of modified transport category aircraft and ex-military aircraft in those situations?
There'll be multiple points to that question, and there are processes that need to be worked through before modified aircraft can be operated in Australia through usually restricted type certification.
Ms. Spence is right. There is accommodation for some of them, but not in every aspect of the aerial work portfolio. It depends on what they want to do, but it's more limited with a...
I'm told Part 138 does authorise ex-military aircraft.
It does, but it doesn't allow them to do everything necessarily.
And there's quite detailed processes that need to be worked through to actually approve those types of aircraft operating in Australia, even for Part 138 operations.
So that's where they would start. It just depends on what they want to do and the type of aircraft.
Right. Okay. Well, I'm rushing through this, but my understanding of what I'm informed here is that ex-military aircraft in the US are an important part of the firefighting capability. And they, in the US, specialist support and direct firefighting personnel are able to be carried on ex-military aircraft. But apparently that's not permitted here. Is that correct?
It's correct, because the US model is different than the Australian model. Those, I think the case you're speaking of is working under the public use model, which is a very different construct where actually it's not governed by an FAA regulation. It's governed by a risk acceptance by the state, and it doesn't have the same oversight.
And
have we looked at that before? I mean, particularly
Absolutely.
Why don't we allow that and the US does?
Senator, we've actually got some work underway, but I think probably one point of clarification, Jonathan can note if I'm wrong, but I didn't think they could actually carry firefighters on those aircraft. Is in the US, they carry, it's more agricultural. I didn't think they were actually able to carry passengers. Yeah. Anyway, sorry.
Well, maybe you could come back on. I'm sure we'll put some questions on notice on that, and we can get some more information. But given the time, we'll move on. Chair, thank you.
I suggest that we went through this at length with Senator Patrick a couple of years ago, and it would be good to dust off those answers because it wasn't very satisfactory at the time. Then there was some talk about exactly this issue about who was being carried on the aircraft. So if we could make sure that your answers align with that.
And they're undertaking some work, has been the answer for a couple of estimates. So eventually we'd like to kind of understand what that looks like.
And I can confirm that we are actively engaging with the various RFSs across the country just to try and understand exactly what they need and where. So I think that there has been a step forward from where we were 2 years ago.
Do you want me to answer?
Yeah.
Yeah, we're done.
Okay, so CASA, thank you very much. Now we have 7 agencies left with